lunch at these times, but
Okay.
it's lunchtime in general.
We will get started about 5 minutes more.
Okay, very well.
Good evening, Professor Hendy Hendarto. Good evening, Professor Georgios Tsoulfas. Good evening, Professor Puruhito. We will get started very soon. Good morning, good afternoon, and good evening, everyone. Welcome to the 17th chapter surgical forum of the International College of Surgeons Indonesia section. First of all, on behalf of the ICS Indonesia section, I would like to express my gratitude for the participation for dear all participants, particularly to our distinguished guest speaker, Professor Rui Manuel Lopes Nunes, the UNESCO Bioethics Chair from Portugal, and the other speaker, Dr. Arina Ikasari Muhtadi, otorhinolaryngeo and head neck surgeon from University of Indonesia, Jakarta, and also Dr. Gunadi is the pediatric surgeon from University of Gadjah Mada, Indonesia, and also for the head office, Professor Georgios Tsoulfas, the world president of the International College of Surgeons from Greece, and Mr. Max Downham, the world executive officer of the International College of Surgeons from Chicago, USA, and also for all office bearers from Indonesia section, Professor Paul Tahlele, Professor Sri Maliawan as the president-elect, and also Professor Hendy Hendarto, the vice president of the section, Dr. Frans Arifin, the secretary of the Indonesia section, and also Professor Puruhito, the expertise board of the Indonesian section. So the theme of this session is the ethical and clinical aspects of surgery. So for the first opportunity in the opening session, I would like to invite Professor Sri Maliawan as the president-elect of the Indonesia section to address the opening speech. Professor Sri Maliawan, the floor is yours.
Thank you, Dr. Peter Manopo. Good evening, good afternoon, and good morning for everybody, especially for the participant, and then for our distinguished guests today. We have now is Indonesian ICS Surgical Forum, Chapter 17. The theme is ethical and clinical aspect of surgery. We have now 3 speakers. Number 1 is Arina Ikasari Muhtadi, MD. She will talk about management of external otitis. And the other one is Professor Rui Manuel Lopes Nunes, MD, PhD. He will talk about ethical concern in surgical cases. And the other one is Dr. Gunadi, MD, PhD, molecular genetic of Hirschprung diseases. As the theme of this chapter, we are talking about ethical and surgical. And then I just a brief review about ethical. The ethical and medical, what we say, surgical ethic, based on every medical doctor know Hippocratic oath. Every medical doctor will know well about this oath. As medical, and surgical treatment become increasingly complex, and as an increasingly educated people move away from the doctors know best paradigm, there is an increasing need for the trainee physician and surgeon to become concerned with the ethical and legal framework of the healthcare system. Medical ethics is a system of moral principles that apply values and judgment to the practice of medicine. So the value of medical ethics, just the main is respect for autonomy. The patient has the right to refuse or choose the treatment recommended by doctors. Relationship between doctors and patient equal partnership basis. Doctor and patient as we again the disease, not anymore paternalistic. And then respect of autonomy is an indicator for both personal well-being and for the well-being of profession. And also beneficent. Doctors should act in the best interest of the patient. Doctors should choose the best treatment for the patient as and he or she has mastered the skill and knowledge of the disease the patient has. Non-malefisant also. Everybody know, every medical doctor know about primum non nocere, first do no harm. Do not treat patient with certain disease if you are not capable and competent to treat. Do not do unnecessary surgery. Do not do unnecessary tests or examination. Do not use treatment. No proven benefit. The treatment was a success, but the patient dead. Justice also, fairness and equality. That is what the main values of ethics. And then let me attend and hearing about the expertise who will talk about ethics, and the other two speakers about genetic and Hirschprung, and the other one about otitis. Once again, last but not least, thank you for your very interesting time to sharing with us all. Thank you again, and thank you, Dr. Peters. That's all. Thank you.
Thank you very much, Professor Sri Maliawan, for the opening speech. For the next, I would like to invite Professor Georgios Tsoulfas, the World President of the International College of Surgeons. Professor Georgios Tsoulfas, the floor is invite Professor Hendy Hendarto, the Vice President of the Indonesia section, to address the scientific notice. Professor Hendy Hendarto, the floor is yours. Okay, I will invite Mr. Max Downham, the World Executive Officer of the International College of Surgeons from Chicago, to address the updates of ICS. Mr. Max Downham, the floor is yours.
Thank you, Dr. Manopo, and on behalf of Professor Tsoulfas, Georgios Tsoulfas, who's based in Thessaloniki, Greece, our world president, and the other leaders of the College of the International College of Surgeons, I congratulate you, Professor Maliawan, Professor Tahalehi, Dr. Arifin, all of the other, Dr. Hindarto and Purohito, for your consistent conduct of these webinars. This is number 17. I think the example that you set and are setting is absolutely terrific. I congratulate you and hope that other sections will emulate what you're doing. I will be very brief this morning, and I should address and thank you for Dr. Muhtadi and Professor Nunes and also Dr. Gunadi. Welcome to you and thank you for your participation in the ICS, this ICS webinar. The key aspect that I will address this evening, your time, is the ICS 42nd World Congress that's scheduled to be conducted in Bangkok, Thailand on November 17, 18, and 19 this year. The website is www.ics-thailand2021.org. The scientific sessions will be a hybrid of both the electronic Zoom, presumably presentations, as well as in-person, face-to-face. The situation overall is a little uncertain. I think the scientific congress will definitely occur on a hybrid basis. But the COVID situation, we are monitoring very closely with the Thailand section leadership. That is really the highlight. Again, I congratulate you, Dr. Manopo, for your conduct of these webinars and the leaders of the Indonesian section. What you are doing is very, very commendable, very impressive. The quality is consistent and high quality, and it's very much appreciated by the leadership of the International College of Surgeons. So thank you, Dr. Manopo.
Thank you very much, Mr. Downham, for your ICS updates. And now I would like to invite Dr. Frans Arifin to address the section notes. Dr. Frans Arifin, the floor is yours.
Thank you very much, Dr. Manopo. There's not much of an update for the business section. I would like to just highlight the updates from the WHO meetings on the international health regulations of the emergency committee regarding the coronavirus disease. On the 14th of July, there is a meeting for the IHR emergency committee, and they are discussing the numbers of the variants of concern for the COVID-19, same as what we are facing now, which is the Delta variant in Indonesia. And on overall, there are notice on the inconsistency of the applications of the public health and social measures, increased social mobility, and lack of equitable vaccine distribution. So we in the ICS encourage every members to participate in improving all of this situation, especially in Indonesia, where the vaccination rate is still low. So all of the members might support the vaccination effort of the government in each of our office or hospitals or society. I think that is all, Dr. Manopo, from the Secretariat. Thank you very much.
Thank you very much, Dr. Arifin, for your address of the section notes. Maybe Professor Georgios Tsoulfas already on the line. Professor Hendy Hendarto. Okay, now we come to the scientific session. And for the first speaker in the scientific session, I would like to invite Dr. Arina Ikasari Muhtadi. She is otorhinolaryngology head and neck surgeon, and she would like to deliver her presentation on management of external otitis. Dr. Arina Ikasari Muhtadi, the floor is yours.
Thank you very much, Dr. Peter Manopo. Good evening from Indonesia to all professors and doctors. Thank you for inviting me And it is a pleasure to be here among all the fellow of International College of Surgeons, especially in Indonesia section. I've been given a topic of external otitis to share with you all, and I'm going to talk about it as a gentle reminder to all of us, as I'm sure that we have already known about this. And our goal is, of course, for us to treat our patient ethically. I would like to share the screen, please.
Sure.
Can you see my screen now?
Yes, perfect.
Okay. So my topic is Otitis externa. And this is the outline of my talk tonight. It's about anatomy and physiology. And we talk about the acute otitis externa and also chronic otitis externa. In acute otitis externa, we can find cases like otomycosis, necrotizing or malignant otitis externa, herpes zoster oticus, and furunculosis. For anatomy and physiology, the auricle is mostly skin-lined cartilage. External auditory meatus consists of cartilage, 40%, and bony part, 60%. It has S-shaped, narrowest portion at the bony cartilage junction. It consists of the auricle and external auditory meatus and skin-lined apparatus, approximately 2.5 centimeters in length, and it ends at tympanic membrane. So otitis externa itself is a bacterial, viral, or fungal infection of the external auditory canal. It's categorized by time course as an acute and a chronic. So we can also see the cause of otitis externa as infective or as reactive. And in infective, we are going to talk about bacterial infection, fungal infection, and viral infection. For the speculum findings using the otoscope, the canal may be so swollen that a view into the ear is impossible. In swimmers, divers, and surfers, chronic water exposure can lead to the growth of bony swelling in the canal, known as exostosis. This can interfere with the drainage of wax and predispose to infection. Acute otitis externa is also known as swimmer's ear. It has pre-inflammatory stage and acute inflammatory stage, which can be mild, severe, or moderate. For the factors contributing to acute otitis externa is high humidity, water exposure, moderate maceration of canal skin, high environmental temperature, local trauma, respiration, allergy, stress, removal of normal skin lipids, absence of cerumens, and alkaline pH of canal. In the physical examination at a glance, we can see the patient with otalgia and tenderness on palpation or manipulation, which called tragosine, and the feeling of ear fullness. We can also find conductive hearing loss, erythema of the meatus and the canal, and swelling and obstruction of the canal, and also crusting and discharge. The typical sign is odor, of course. For the labs, we can usually take for examination after we failed empiric therapy. We can take a bacterial and fungal culture, and with adult with otitis externa, we can also use the screening blood glucose and or a urine dipstick test to rule out occult diabetes. Additional tests, if available, we can also take gram stain of the discharge or KOH preparation smear within 10 minutes. In the pre-inflammatory stage, usually we find oedema of the stratum corneum and plugging of upper pilosebaceous unit. The symptoms, pruritus, and the sense of fullness, and the signs is mild edema. It starts with the itch and sweat cycle. In mild to moderate stage, it shows a progressive infections, and the symptoms is pain and increased pruritus. The sign is erythema, increasing edema, and canal debris discharge. In the severe stage, the pain becomes more severe, worse with ear movement, and the signs, we can see the lumen obliteration, purulent otorrhea, involvement of preauricular soft tissue. For the treatment, because of the most common pathogens are Pseudomonas aeruginosa, Staphylococcus aureus, Escherichia coli, and Proteus. So our 4 principles, we have to do the frequent canal cleaning, swab or suction. With severe external otitis, placement of a wig made of sponge of gauze provides a pathway for the drops to be delivered to the external ear canal wall skin for about 48 to 72 hours. Topical antibiotics, and if severe, we use systemic per orally, and also pain control, and we give instruction for prevention. Excuse me, can you still hear my voice? Hello?
Yes, very clear.
Okay, because I just got a sign that my internet connection is not stable. So just yell at me if you don't hear me, please.
Sure.
Now we're going to continue. We're going to talk about the first acute otitis externa, which is otomycosis, mostly in children who are exposed to warm, moist climates, or who have a history of chronic use of antibiotics, ear drops. Fungal infection of the external auditory canal skin. It can be primary or secondary, and most common cause organism is Aspergillus and Candida. The sign usually canal erythema with the mild udem, white, gray, green, yellow, or even black fungal debris. The symptoms is often indistinguishable from the bacterial otitis externa. Pruritus deep within the ear with the otorrhea, dull pain, and hearing loss because of the obstruction, and sometimes with the tinnitus. The treatment through thorough cleaning and drying of the canal. You have to make sure that it's really clean, and we give the topical antifungals such as chlorotrimazole, for example, amphotericin B, oxytetracycline polymyxin, and nystatin are very effective. Acidifying of the external auditory canal with drops like 2% of acetic acid or 3% boric acid or Sulzberger's powder are also helpful in the treatment of fungal infection. The second one is what we call necrotizing otitis externa or malignant otitis externa. Potentially lethal infection of the external structure. Pseudomonas aeruginosa is the usual culprit, and the risk factors usually diabetes mellitus, elderly, immunocompromised state, and human immunodeficiency virus or HIV. Typically seen in diabetes patient and immunocompromised patient. The sign and symptoms similar to otitis externa, except it's more severe, unrelenting ear pain and headache, persistent discharge, does not respond to the topical medication, and commonly associated with diabetes mellitus. Granulation tissue in the posterior and inferior canal is the pathognomonic for this necrotizing otitis and occurs at the bone cartilage junction. External auricular finding is and facial nerve palsy of paralysis, such as Bell's palsy, associated with the poor prognosis. The prognosis reported mortality is 20% to 50%. And for the diagnosis, we use labs like full blood count, culture of discharge, serum glucose, serum creatinine, and radiology if necessary, CT or MRI. Prevention, we avoid use of cotton swab in the ear and other canal trauma. Use caution when irrigation ear of the high-risk patient, and treat the eczema of ear canal and other pruritus dermatitis. And treatment, usually patient is hospitalized with intravenous antibiotics for at least 4 weeks with serial gallium scans monthly, and local canal debridement until healed, pain control, use of topical agents still controversial, and there are some experimental of using the hyperbaric oxygen. Surgical debridement is only for refractory. Cohen and Friedman give the criteria of 2 types, obligatory criteria and occasional criteria. Obligatory criteria include pain, edema, exudate, granulation, microabscess when operated, and positive bone scan, TC99 scan, usually for detecting the osteomyelitis. Failure of local treatment more than 1 week, and then possibly of pseudomonas in culture. But when bone scan is not available, a trial of 1 to 3 weeks of local treatment is suggested. For the occasional criteria, we can find diabetes, cranial nerve involvement, positive radiograph, debilitating condition, and old age. Mortality, death rate essentially unchanged despite of newer antibiotics. Higher with multiple cranial neuropathies, and recurrence not uncommon, may recur up to 12 months after treatment. The third one of the acute otitis externa is herpes zoster otitis, or we call it Ramsay-Hunt syndrome because it was described by J. Ramsay-Hunt in 1907. It is a viral infection caused by varicella zoster. Infection along one or more cranial nerve dermatomes or shingles. It can be found herpes zoster of the pinna with otalgia, facial paralysis, sensorineural hearing loss, bullous meningitis in the tympanic membrane, and vascular eruption of the concha of the pinna and the external auditory canal. The symptoms in early stage, we can find a burning pain in one ear, and then headache, malaise, and fever. In the late sign symptoms, 3 to 7 days, it can be vesicles or facial paralysis. And the treatment is corneal protection, oral steroid taper 10 to 14 days, and antivirals such as valacyclovir. Facial nerve decompression is still controversial. The fourth one, we talk about furunculosis. It is an acute localized infection. It happens lateral 1/3 of the posterior-superior canal, obstructed of upper sebaceous unit. Yes? And pathogen is Staphylococcus aureus. The furunculosis symptoms give localized pain, pruritus, hearing loss, if lesion is occluded canal. The sign is edema, erythema, tenderness, occasional flatulence. And the treatment, we give local heat, analgesic, oral anti-staphylococcal antibiotics, and incision and drainage receive for a localized abscess, and IV antibiotics for soft tissue extension. Now the next one is the chronic otitis externa. Acute otitis externa occurs in 4 of every 1,000 people per year. Imagine that. And otitis externa is defined as chronic when the duration of the infection exceeded 4 weeks, or when more than 4 episodes occur in 1 year. Bacterial, fungal, and dermatological becomes the etiologies. So chronic otitis externa gives symptoms unrelenting pruritus, mild discomfort, dryness, crusting, and flaking of canal skin. And the sign, we can see the steatosis, dry, flaky skin, hypertrophied skin, and mucopurulent otorrhea is occasional. For the treatment, it's similar to this to the acute otitis externa, with topical antibiotics, frequent cleanings, and topical steroids. Surgical intervention is only if the failure of medical treatment. The goal is to enlarge and resurface the external auditory canal. Thank you for your attention, and I come back to you. I give it back to you, Dr. Peter Manopo.
Thank you very much, Dr. Arina Ikasari Muhtadi, for your informative presentation. And now I would like to invite the second speaker, Professor Rui Manuel Lopes Nunes, the UNESCO Bioethics Chair from Portugal, to deliver his presentation on ethical concerns in surgical cases. Professor Rui Nunes, the floor is yours.
Thank you very much. Firstly, I would like to thank the invitation.
Professor Rui Nunes?
Yes?
Kindly unmute your microphone.
if it is expected for me to begin. You are hearing?
Yes, very clear.
Okay. So, first of all, I would like to thank the invitation, the nice invitation of Dr. Peter Manobo. It is always a pleasure being with you. And a formal thanks to the International College of Surgeons of the Indonesia section in this 17th chapter of the Surgical Forum. So thank you very much for the invitation. I'm very happy to be here representing the International Chair on Bioethics. And I'm going to make a brief presentation, a 20-minute brief presentation on the ethical concerns of severe surgical cases. Well, first of all, as it was said by the President in the opening speech, medicine always had a common set of principles that all over the world were and still are a part of our Hippocratical oaths, meaning that every physician anywhere in the world must abide to a common set of principles that have more than 2,000 years and that in practice mean that the best interest of our patients, the principle of beneficence, is our guide. So all of you, all of us, every healthcare professional really has this commitment, this internal oath to himself or herself, to the general community, to make the best and have all his or her competence to make the good to our patients. If there were any doubts about this pandemic, this COVID-19 pandemic all over the world is a good testimony that physicians always are in the first line of defense of the patients, even when their lives are at stake, their psychological integrity is at stake. There are many studies all over the world that show the terrible numbers of burnout, of professional burnout by physicians and other healthcare professionals. Why? Because the moral dilemmas, the moral distress they had and still have during this pandemic make them, on the one hand, doing the best they can, but on the other hand, knowing that sometimes is really not possible. In every country, even in developed countries, sometimes resources were not available to all patients, namely in intensive care, as you all know. So these are strong dilemmas for physicians all over the world, in every country. But the main principle is this devotion to the patients. And of course, as it was also said, trying to not harm patients, primum non nocere. It was already stated in the opening ceremony. So, of course, all of us want to do the best we can, but sometimes we go a little bit further than we should go, and we do harm. We should try to avoid that every day of our lives. But on the other hand, if this Hippocratical medical ethics, traditional medical ethics, paternalistic medical ethics is still very, very important in our lives, when we treat an external otitis, like Dr. Arina Ikasari, of course, she does all she can to treat that patient very, very well. I have no doubts about it. But we must also realize that we live in a modern era, in a global world, and there are some principles, new principles, that we should take into consideration. And it is this new group of principles that might collide sometimes It is not very often, but might collide with traditional medical ethics. For instance, the principle of respect of human dignity, meaning that every person is a human being that deserves respect due to his or her intrinsic value. And of course, if the human being has intrinsic value, there is now a group of fundamental rights that every one of us should be allowed to have, and they should be complied with in medical practice. One of them is precisely the respect for personal autonomy. This is a new principle in medical ethics. It has 20, 30, 40 years ago. It depends on societies. Firstly at the United States, but then all over the world, it was recognized that patients have the right to choose, the right to make informed choices, the right to give proper consent. So I would say that this new principle, together with other new principles, but I'm not going to speak about them today because we don't have time for that. Namely, the principle of justice that was already spoken of in the opening ceremony. It is a very, very complex principle, the principle of distributive justice. But again, I would emphasize this need for proper consent so that medical practice is in accordance with this new set of principles of biomedical ethics. In this environment, ethical environment, I would say that there are now some challenges, 3 or 4 huge challenges for every physician, but for surgeons in particular. Namely, as I told before, and as we are all aware, physicians must do the good and avoid harm. But the million-dollar question is, what does it mean today doing good and avoid harm? It is a very complex question. Why? Because, of course, every one of us as a physician has his or her own experience. And we know we have had our instruction at medical school. We learn from our teachers, from our colleagues, from more developed surgeons, for instance. But does it really mean that we are doing good? This is the first question. How can we answer this question? Well, nowadays, at the global level, we try to answer to this question through the creation of a new and vibrant field of medicine that is evidence-based medicine. So, if you ask me, what does it mean to do good and avoid harm in medicine today? I would say, of course, the physician must be well prepared, competent, diligent, must be devoted to his or her patients, of course, but the medical practice should be guided, if possible, it is not always possible, but if possible, by evidence-based medicine. So, of course, what does it mean? It is a general standard. Usually we refer to leges artis, meaning the laws of medical practice, the principles, the good principles of medical practice. And I would say that we should abide to the principles of good medical practice, namely to evidence-based ones. Why? Firstly, because it should be like that in principle. That's what medical ethics determines, but it has also a preventive nature. Why? Because, as you know, I don't really know what happens today in Indonesia, but in most countries, there is a steadily growing number of liability lawsuits. So I would say that abiding to evidence-based guidelines would be, of course, a very good receipt to avoid liability, because if we act in medicine as the guidelines determine, of course, we are doing the good and we are avoiding that malpractice lawsuits are at stake. So this would be my first challenge and conclusion: evidence-based medicine. Secondly, we should have a diligent practice and an administrative one at the hospitals and other clinical environments of getting proper informed consent. Of course, it is not easy to speak and to explain informed consent, because it is a very complex concept, but nevertheless, it means that for most medical interventions, and I would say for every surgical intervention, proper consent must be obtained. And what does it mean, proper consent? By proper consent, it is meant, firstly, that it is a free consent. So patients must give consent in a free environment. So physicians, nurses, family members should not coerce patients to deliver proper consent. Consent must be free. Secondly, it must be informed. Of course, there is a huge disparity in knowledge between physicians and patients, but this does not mean that we physicians should not try to explain in simple words what does it mean to treat or to operate on a patient. For instance, a radical case, if a surgeon is going to operate on a patient and make a laryngectomy, so to extract the larynx, of course, the patient must be properly informed of the consequences of these surgical procedures. It is not acceptable that he or she, after the surgery, feels that he or she cannot speak anymore because no one told this was a dramatic consequence of surgery. Of course, this is an example. Much more examples could be here suggested, but I would say that the overall meaning of proper consent is that we should adapt the level of information to the level of the patient, to the intellectual level of the patient. But this does not mean that important information to decide as a reasonable and prudent person would decide. So our standard is the reasonable and prudent person. This, of course, must be our line of action, to feel what a prudent person, a reasonable person would like to know, adapting the language, the information to that specific patient and getting proper consent. Of course, we don't have the time. If we had, we would speak about getting informed written consent. In some countries, it is a legal obligation. In other countries, it is not. But nevertheless, I would say it would be ethically adequate, even mandatory, that in surgery, surgeons get written consent. I'm not saying that written consent, it is an alternative to proper expressed consent in a dialogue and a frank dialogue with the patient. I'm not saying that. I'm saying that written consent should be obtained, namely for avoiding civil liability and medical malpractice lawsuits. So it is more a legal safeguard than an ethical one. But nevertheless, I would strongly recommend that, of course, you get written consent. We don't have the time. If we had, I would speak also of advanced directives. For instance, when a patient, I'm not sure if you have that circumstance in Indonesia, but in Europe is very frequent for patients due to religious motives do not accept blood transfusions, and it is a huge ethical problem when there is a very important surgery to be performed, and the patient has an advanced directive, a living will, stating that he or she does not accept a blood transfusion. So this is also a huge challenge to all physicians and specifically to all surgeons. Thirdly, I'm going to be a little bit faster. Thirdly, I would say that another challenge would be the challenge of this 4.0 digital transition. The world will not be the same after this pandemic, because the digital transition that already began before the pandemic, but nevertheless, it's now much faster, because the pandemic made all of us going much faster in this digital transition. So all of us must be acquainted with dealing with artificial intelligence, robotics, big data, lake data, new ICT technologies, and specifically, so my third challenge would be specifically with electronic records and the need for data protection. So data protection is an absolute value. For instance, in Europe, protection of data, protection of personal privacy is very, very important, is almost as important as life itself, because it protects something that is our genetic endowment, our individuality. It protects our own personal identity. So I don't have the time, but nevertheless, please take this into consideration, that in the future, stronger rules, stronger laws, stronger ethical guidelines will be needed, will be put forward to protect personal privacy in general, but specifically the patient's privacy and personal data of the privacy. Just to give you an example, we had one of my PhD students in bioethics just defended yesterday her PhD thesis about data protection and the right to be forgotten. What does it mean? That because modern society did not protect privacy as society should, now a brand new fundamental human right has been proposed, and at least in Europe is law, that is the right to be forgotten, meaning that patients now have a right to say to their physicians that their data should be erased from the electronic records, medical records. So it is a very important issue that, of course, societies such as the International College of Surgeons not only should be aware of, but should implement measures to their associates, because it is a global movement. Because, as you know, modern technologies, modern ICT technologies, namely through artificial intelligence, put this question in another different level, because in principle, artificial intelligence can search for every data of every one of us anywhere in the world. So stringent ethical guidelines are needed if we want to keep the trust of our patients. I remember all of you that the patient-physician relation is a fiduciary relation, a relation based on trust. If trust is not at stake, patients will not believe us, and we will not be good physicians and good surgeons. So please keep this in mind. Finally, well, my time has run out, but nevertheless, I would say that special attention is needed in clinical trials, namely of new surgeries, because nowadays, everywhere in the world, there are stringent guidelines. Due process is needed. It is not acceptable that an ethos, an ethical background stating that medicine, surgery, science should evolve, taking into consideration the needs of humanity, the development of science, the development of society. This should be balanced with the fundamental rights and interests of the patients. So I can assure you that this is one of the main tasks of ethics committees, is to balance the need for science to develop on the one hand, and on the other hand, the fundamental values and the fundamental rights and the interests of the patients. It is very interesting because after World War II, in the Nuremberg trials, the Nuremberg Code stated precisely this. First, informed consent. Secondly, that the interests of the subjects, of the patients, should be ahead of the sole interests of science. But again, I feel that after almost a century, the same problems, not of course such a gravity, but the same problems still arise, and ethics committees, and I feel that many of you will be members of ethics committees, deal with this issue every day. So this pressure of science to develop, but nevertheless not taking totally into consideration the interests of patients. Of course, this is a very delicate equilibrium. Of course, that medical associations such as yours have strong responsibilities in this matter, because surgery must develop, but respecting the human rights of the patients. And it is not impossible to do so. Science developed in an astonishing way in the last decades. See, for instance, the new COVID-19 vaccination. And so we can respect human rights and nevertheless make good science, and in this case, new surgical procedures or new treatments for surgeons to use in their daily practice. So my time has run out. It was a pleasure. If you wish to open discussion, I will be most pleasure. If not, thank you very much again for the invitation.
Thank you very much, Professor Rui Manuel Lopes Nunes, for your very important presentation. We will keep the discussion after all speakers completed the presentation. For the next opportunity, I would like to invite the next speaker, Dr. Gunadi. He is a pediatric surgeon, and he will speak on the molecular genetics of Hirschprung disease. Dr. Gunadi, the floor is yours.
Thank you very much, Dr. Peter Manopo. May I share the screen?
Sure.
once again, thank you very much for the opportunity to share our experience regarding the genetics of Hirschprung disease. Can you see my screen?
Yes, perfect.
Okay, thank you. My name is Gunadi. I'm from Universitas Gadjah Mada, Dr. Sarjito Hospital.
Good. Okay.
Yeah, actually, I will talk not only about molecular genetic of Hirschprung, but also clinical manifestation of Hirschprung disease, current management of Hirschprung disease, and also what happened to the patient after pull-through procedure. Hirschprung disease is a complex genetic disorder characterized by lack of ganglion cells in the intestines, resulting in functional obstruction in children. Interestingly, the incidence of Hirschprung disease is in Asia even higher than European one in 5,000 live births, in Asian even higher, one in 3,500 live births. And moreover, male is more prevalent than female, and actually more than 24 gene and including microRNA involved in the pathogenesis of Hirschprung disease. How about Indonesia? And the gene is involved in pathogenesis Hirschprung disease, including rat, NRG1, etc. How about Indonesia? Even higher. The incidence is 1 in 3,250 live births. This is the clinical feature of baby with Hirschprung disease, abdominal distension. And why we consider Hirschprung disease as genetic disease? There are several reasons. The first, after some pediatric surgeon found or discovered pull-through, then the survival of patient becoming longer, then we can do research in the patient. And the second, there are higher risks for sibling to have Hirschprung disease after another sibling have a disease. And then there is a discrepancy between male and female to having Hirschprung disease. And the fourth reason, there is also syndrome beside the isolated Hirschprung. And fortunately, there are animal model for Hirschprung, then we can manipulate for doing research to confirm that Hirschprung disease is a genetic disease. And this is a pull-through. And this is the sibling having Hirschprung disease. And one of the syndrome of Hirschprung disease is called Mowat-Wilson syndrome. And this is how we study of genetic on Hirschprung disease using animal model. And then starting 1980, when men coincidence, one patient have man tumor and Hirschprung disease, and then they looking for which chromosome, and we at the time the researcher found that men to locus deletion in chromosome 10, and they think that Hirschprung also lies in chromosome 10. And finally, they found rat as the most responsible gene for Hirschprung disease. And this is the rat gene, and then located in chromosome 10. And then, as I mentioned in the earlier, that during gestational age of 5 to 8, the ENS or enteric nervous system develop in the embryo, and then if the ENS fail to normally develop, then becoming Hirschprung disease. And actually, the ENS not only derived from vagal neural crest cell, but also consists of a little bit sacral neural crest cell, and also anterior trunk neural crest cell. But predominantly, the enteric nervous system derived from vagal neural crest cell migrate from cranial to caudal. Is the green one. And then ENS development is very complex process regulated by specific gene expression. There are many genes and many microRNA involved in the enteric nervous system development, including NRG1, RAD, etc. And they affect the proliferation, migration, and differentiation of enteric neural crest cell. And then the manifestation of patient of Hirschprung disease, they can be sporadic, only one patient in one family, or even familial. There are several patients in one family. We classify the 24 genes into 4. In the first category is pathway of RAD, GFR alpha GDNF. The second pathway EDNRB, ECM1, EDN3. The third pathway is SOX10 FOX2B, and the fourth is semaphorin 3C and 3D. How about the epigenetic role during the ENS development? Actually, ENS development derived from neural crest cell development, and they during the development of neural crest cell, they involve the DNA methylation, polycomb repressive, histone modification, and ATP-dependent chromatin remodeling. All processes affect the NCC development. And then after that, they, of course, they will affect the proliferation, migration, survival, and differentiation of neural crest cell to becoming, to develop enteric nervous system in our intestine. So that's why they also involve microRNA, long non-coding RNA, circulation RNA, etc. And this will drive the future therapy of Hirschprung disease. And this is our experience how the genetic different susceptibility and specific genetic expression in Hirschprung patient, particularly in Indonesian patient, is very somehow is different from Caucasian. I will explain later. Then how do we diagnose of Hirschprung disease? Of course, the first is clinical manifestation, and then imaging. And how about the gold standard? The gold standard international is histopathological finding of Hirschprung disease. And we can use the simple of hematoxylin eosin to see whether there is a ganglion cell. If the lack ganglion cell, it means Hirschprung disease, and hypertrophy of trunk. There are two characteristic of histopathology of Hirschprung disease. The first one, no ganglion cell, and the second is hypertrophy of trunk. And if we want to make more clear what rather than hematoxylin eosin, we can use immunohistochemical such as S100 to see the hypertrophy of trunk, or we can use calcium. If we see the left side is there is no ganglion cell at all, it means the patient having Hirschprung disease. However, if we see the right side, if this is the brown is the ganglion cell, it means calcinin positive. It means ganglion cell exists in the intestine. Then the patient has this is the control. How about the current management of Hirschprung disease? I mentioned earlier that usually the patient, the baby, after birth, there is meconium delay more than 24 hours. And then if the baby becoming older and older, they will have chronic obstruction. And of course, they may have enterocolitis. And then we have to do first the compression for the patient. If the compression is failed, we may consider doing stoma on the patient. However, if the compression is successful, and then we determine the diagnosis of Hirschprung disease by imaging, contrast enema, and finally the gold standard of biopsy. And of course, the definitive surgery is pulled through for the Hirschprung disease. how about the where the genetic tools place for management of Hirschprung disease? Actually, the place of genetics tool in management of this disease is to make genetic risk factor stratification, to make family more aware that the Hirschprung disease is a genetic disease. About the pull-through, now currently they use minimal invasive, whether laparoscopic, the more common than robotic. I think robotic is not so advanced for pull-through. And how about if the patient having total chronic aganglionosis, there are several options of the pull-through. And then this is the more common performed by a pediatric surgeon over the world, transanal endorectal pull-through, either endorectal or swab or Swenson-like pull-through. And this is the picture of Swenson-like transanal endorectal pull-through. And also in our institution, we also perform laparoscopic assisted transanal endorectal pull-through and also laparoscopic Downham pull-through. And now let's move to future therapies. The future therapies of Hirschprung, there are several options. The first cell-based therapy, and the second drug-based therapy, and the last is genetic manipulation. Cell-based therapy, everybody I think here already have knowledge about embryonic stem cell, and then enteric nervous system stem cell, and induced pluripotent stem cell. And how about drug-based? This, according to epigenetic mechanism involved in Hirschprung disease mechanism, so that's why they develop SDAC inhibitor, DNMT inhibitor, and then the last one decade that we our world have so bright on CRISPR-Cas9 genetic manipulation. And this is how the cell-based therapy developed. This is patient-derived fibroblast. It means this induced pluripotent stem cell. That's the stem cell derived from the mature cell. And this is the embryonic stem cell, means the stem cell coming from the blastocyst or embryonic stem cell. And this is still ethical issue in if we use embryonic stem cell. And the third cell-based therapy option is coming from patient guts, the stem cell from patient guts. And how about drug-based therapies is also, I think it's still in vitro. It's not in clinical trial, of course. And but the result of in vitro is promising. And then genetic manipulation, they try to use CRISPR-Cas9 to develop even the induced pluripotent stem cell. And now we talk about how the genetic tools impact on the clinical management of Hirschprung. Like I mentioned earlier, that the genetics tool affect on Hirschprung risk stratification. There are several polymorphism or common variant involved in the development of Hirschprung, such as RED, RS2435337, etc. And if we see the incidence of the polymorphism even higher in Indonesia or Asia, so that's why the Hirschprung disease incidence is higher in Asia than European. This is the reason. We see the allele key, the mutant allele, in European only 27%. However, in Asia is very higher. Yeah, in Asia is in the control 50%. I think all of us contain one of the allele. And then if we see the how many, if we compare how many risk allele we do have and the risk of Hirschprung, and this is interesting that if we do have only 1 or 0 or 2 risk allele, this is even protective. However, if we do have 5 or 6, the risk having Hirschprung disease becoming 9-fold. And then if we use the correlation, it's very high, almost 1. Yeah, This is the correlation between the number of risk allele in the patient and the risk of Hirschprung disease they have. And then we move to the functional outcome and enterocolitis after pull-through. What does mean functional outcome? Functional outcome after pull-through consisting of three outcomes. The first, voluntary bowel movement, and the second is soiling, and the third, constipation. Voluntary bowel movement, the feeling of an urge to defecate, and the patient have capacity to verbalize that they want to defecate. And then the third, the most important, they can hold the bowel movement. It means the patient after pull-through have good voluntary bowel movement. And how about the soiling? Soiling consisting of three grades. The grade 1, occasionally soiling, once or twice a week. Grade 2, soiling almost every day, but still no social problem. However, if soiling grade 3, they will affect the social problem. And this constipation also grade, there is 3 grade. Grade 1, manageable by changes in diet. Grade 2, require laxative, and grade 3, resistant to laxative and diet. And of course, they have to assess by pediatric surgeon at least if the children already reached 3 years old. And this is our research, regarding the constipation and voluntary movement and soiling. There is no difference between SWAF and Duhamel transabdominal pull-through, except the constipation, significant between SWAF and Duhamel. And this is how about the transanal endorectal pull-through. The voluntary bowel movement, if you see between SWAF 88% and this 82, almost comparable. And the swelling this 8 and this 18%, constipation, yeah, almost 8, and this is around 20. How about another, because the constipation is different between SWAF and Duhamel procedure, we want to know which prognostic factor affect the functional outcome. And this the frequency is higher in the SWAF, 24%. And the gender actually is more as a risk factor for having constipation, the female, 21-fold. And after transanal, this is after transanal functional outcome, which prognostic factor, similar, sex is a strong risk factor for voluntary bowel movement, while the post-operative complication is the strong prognostic factor for constipation. How about the enterocolitis? Enterocolitis, we use in our hospital using the Delphi method, high scoring system, yeah, developed by Delphi method, and there are several items to be calculated. And then this is the most patient having history of enterocolitis, dilated loop bowel, distended abdomen, shift to the left. And if you compare the enterocolitis incidence between Duhamel and SWAF pull-through, is significant. And interestingly, if the patient having enterocolitis before surgery, and then the risk of having enterocolitis after surgery higher, 8-fold. And then next, we want to compare how actually the cutoff of enterocolitis scoring system. And we use the current, we compare the current cutoff of 10, and then and then another researcher developed 4, the cutoff 4, and then we compare the incidence of high. Of course, if we use cutoff of 4, is higher than if we use the cutoff of 10, and very significant, 45% compared to 70%. In conclusion, the first INS, trach nervous system development, is very complex process in which a large number of molecules that are tightly regulated by specific gene expression. Hirschprung is a complex genetic disorder results from a failure to fully colonize the intestine by entering neural crest cell derived from neural crest cell. And then genotype specific of patient will provide the basis for risk stratification and genetic counseling for the families. And the fourth, functional outcome and endocrinologists after pull-through should be evaluated regularly. And the last, not the least, the lower cutoff value of 4 might increase the possibility to diagnose enterocolitis, particularly the mild cases. Thank you very much, Dr. Peter Manopo and all audience.
Thank you very much, Dr. Gunadi, for your very informative presentation. Before opening the discussion, I would like to invite Professor Purohito to address the summary notes. Professor Purohito, the floor is yours.
Thank you, Dr. Peter Manopo. Good evening, everybody. Talking about the summary notes from we have heard so far, a surgeon competence consists of her or his attitude, namely number one, on time and need, and he or she should able to make a good decision making with his balance, and should always pay close attention to the special needs and circumstances of the individual patient, and he or she can do right surgery on the right patient at the right time. The technical skills of our surgeons should be enough to be able to perform surgical intervention with a minimum risk and great chances of success. The practice of surgery is actually based on the technical capabilities of the surgeons, their knowledge, and their capacity of judgment. But the clinical aspect of surgery could be defined as the action of man upon man. So during a surgery, there is always an action by one person, namely the surgeon, upon another person, the patient. So the surgeon does require to complete surgical procedures, which is different from other medical specialties. Talking about decision making in surgical practice, it should consist of based on appropriateness, acceptability, and standard of care. In order to make decisions, surgeons need to be virtuous in modest qualities. For example, perseverance, punctuality, fairness, honesty, kindness, and teamwork. And in making a decision, a surgeon have a performance technique sufficient to perfectly master the complex of art of surgery. So the ethical principles in the surgical care of patient are surgery. First, surgery is often sought or considered for several patients for whom futility discussions are most relevant. Secondly, the surgical interventions has great potential for harm to the patient and routinely requires balancing the ethical principles of the beneficence and the non-maleficence. Third, surgery requires the consent of multiple agents, namely the patient, surgeon, and the anesthesiologist. Questions of patient autonomy and a physician's obligation to provide treatment are common in futility discussions and can be especially complex in cases in which surgical intervention is being considered. So to summarize, the core of surgical ethics is the surgeon-patient relationship and the surgeon's responsibility to advance and protect the well-being of patients. And it emerged to examine problems specific to surgeons. These problems are closely linked to the development of science and technology. The three central ethical aspects of modern medical practice, which is also mentioned by Professor Nunes formally, is the clinical competence, respect for patients and their healthcare decisions, and last but not least, maintaining the primacy of the patient's need in the face of external pressure and the changing social, economic, and political issues. That's all what I can summarize, summary note for this session. Thank you very much, Dr. Peter.
Thank you very much, Professor Puruhito, for the summary address. Now I would like to open the discussion, and the first part of the discussion will be the inter-speakers discussion, the expert discussion. So before opening to the floor, each speakers could ask question each other. So I will give the first opportunity to Dr. Arina. Dr. Arina, do you have any question to the other speaker? Dr. Arina? So I will skip to Professor Rui Nunes. Professor Rui Nunes, do you have any question to the other speakers?
No, thank you very much. There were excellent speeches. Thank you.
Okay. Now I would like to invite Dr. Gunadi. Do you have any question to the other speakers?
No, thank you very much.
Yeah, I have a question to Professor Rui Nunes. To what extent we could protect the confidentiality of the data of the patient? Because if the patient come to the hospital, the more illness of the patient means the more data needed for the diagnostic and therapeutic procedures. So the more possibility for breaching the confidentiality of the electronic digital data. So would you please elaborate this concern about the risk for breaching the confidentiality of the patient data? Thank you.
Yes, thank you, Dr. Peter Manopo, for your excellent question. And I would say that first thing is all of us, beginning by physicians and surgeons, but also nurses, all healthcare professionals, everyone who deals with patients with electronic records must be obliged, mandated to comply with professional secrecy and protection of privacy and personal data of patients. So this is would be the rule number one, that a pedagogic setting, instruction of all healthcare professionals, namely professionals that do not initially have a healthcare professional training, such as lawyers or managers of institutions. So everyone must know that he or she that deals with patients has a special obligation. It means that, for instance, there should be ethical codes for everyone, for every profession that deals with patients. For instance, nowadays, managers, so economists, etc., that run institutions have an ethical code in many countries so that they know that although they are not typically a healthcare professional, nevertheless, they have special obligations. So the first conclusion would be we should all, as healthcare professionals, put forward our teaching obligation, not only to colleagues, but to general society, to protect these values. Secondly, I would say that it is also a matter of culture, because although privacy and protection of data and professional secrecy is in democratic oaths, namely the oath to protect the privacy of patients, nevertheless, sometimes all of us tend to not be so firm and steady in this protection. So, teaching on the one hand, secondly, all of us should be more stringent, more able, more diligent to protect patients' privacy, that it is in the future our privacy, because all of us in the future will also be patients. Thirdly, in the digital era, I would say that the healthcare system and organizations, complex organizations such as hospitals, should put in practice new technological instruments to protect personal data. For instance, traditionally in my country, in Portugal and many European countries, there is an intranet, digital intranet in a hospital, and all physicians have access to that intranet. And so theoretically, although it is unlawful and unethically, but every physician can go and see the data of any patient, although it is not his or her patient. This is unacceptable. So we should implement digital solutions that protect privacy, meaning that only physicians, nurses, surgeons that will with the patient can have access to the data of that patient. So there are other solutions, but I think that in this setting we could do a lot for privacy, a lot for protecting human rights, and a lot for protecting also this ethical universe that is patient-physician relation. This belief that physicians care for patients, protect them against anything else in the world. So it is a huge path, but I think that we can do it if you want really to do it. And nevertheless, in specific circumstances, for instance, an epidemiological study in COVID-19. Of course, there might be specific public health interests that allow for studying and investigating on electronic records, but it should be a very stringent protection, because in the end it will be better off for all of us, for society, for patients, and for physicians.
Thank you very much, Professor Nunes, for your explanation. I have one question for Dr. Gunadi. Dr. Gunadi, you said that the other treatment for the Hirschprung disease is stem cell treatment. My question is, how about the ethical concern in your stem cell treatment in Hirschprung disease? Because we know in the embryonic stem cell, we have to respect the embryo as the potential human being. So if you do something, you will make an intervention. So this could be inflict a ethical problem. Have you any explanation about this?
Thank you very much for the question, Dr. Peter Manopo. Actually, for the stem cell, particularly the embryonic stem cell, always there is ethical issue if we use the embryonic stem cell, even in United States or in developed country, and of course in our country. So that's why the researcher developed another stem cell, such as induced pluripotent stem cell, and also the stem cell directly from the intestine of the patients. So I think it's no for two dose stem cell, there is no ethical issue, I think, but we can discuss with Prof. Nunes and Prof. Other speaker here, because the induced pluripotent stem cell derived from the mature or differentiated stem cell. For instance, the 5 fibroblast, it's already differentiated, and then put some of transcription factor etc., and then becoming induced pluripotent stem cell. And then the second option of stem cell coming derived from the intestine of the patient itself. It's not embryonic, of course, because it's already exists in the patient, and we taken out some of them, and we growth in the plate, and then we of course now in the in vitro, in the in vivo, in the animal model, not in the patient yet. However, if the result is promising, I think in the future we can implant the patient intestine stem cell to the patient themselves. Thank you. Please, Professor Nunes or other speaker, any comment? Because I'm not the expert of ethical issue.
Okay, thank you very much, Dr. Gunadi. Professor Nunes, do you have any comment on this issue?
Yes, I will make just a brief comment, because this is such a huge ethical problem that it would need another conference to deal with it. But nevertheless, I would say that, as you know, in all countries in the world, there is a strong division between people that believe that the human embryo is a person since conception, since fertilization, since syngamy. And there is another group of people in every country that feels that it is not yet a person, but a potential person. So this is a dilemma that it is not yet been solved anywhere in the world. So we try to have stringent guidelines so that research on human embryos is kept to a minimum, just to very specific cases where there is no other alternative. But in this case, as Dr. Gunadi stated, the stem cells might, or in this case, did not came from human embryos. So if a stem cell belongs to a human embryo, if we have that stem cell, we may put at risk the life and integrity of that embryo. And so many people feel that this is wrong because it is human life. But if we have human cells, human stem cells, not from human embryos, but from any other tissue or organ, of course, the ethical problems still exist, but are on a very different level. Because the ethics is only about the destiny and the consequences of that research. Of course, that stem cells have, at least the embryonic ones, have all the potential. They are totipotential. So even they can lead to a new human being. I'm not sure if the stem cells Dr. Gunadi told us about have this potential, or only the potential to give a specific tissue or organ. But nevertheless, the end of the research is also ethically problematic. And so, as I stated before, every guideline, every ethical national and international guideline should be respected, so that surgeons and physicians and scientists keep their prestige and moral integrity. But again, I agree, it is not the same thing to collect stem cells from a human embryo. Is a very delicate question than getting and collecting cells from anywhere in the human body. And of course, taking into account informed consent, physical integrity, etc. If all those ethical principles are respected, I think that in some circumstances, in very good scientific projects, supervised by the ethics committees and other agencies on research, of course, that science must go on.
Thank you very much, Professor Nunes. Professor Purhito, do you have any question?
No, thank you. It's clear everything.
Yeah, thanks. Dr. Frans Arifin, do you have any question? Dr. Frans, are you on the line? Okay, we'll open the discussion to the floor. Any question from the floor? You can ask directly.
Dr. Peter, can I ask the questions to
Sure.
Professor Nunes?
Yeah,
Yes.
sure.
As you see, our clinical trials are now interviewing with the basic of biology. We create, we cut and assemble the DNA, as Dr. Gunadi mentioned, in using CRISPR, and this in turns does not affect only a single individuals. This in turns may affect the offspring of these individuals and the next generation of human being. So how do you know that any intervention to the genetic in genetic manipulation will be good or bad for the future of humankind? Maybe it's good for the individual, but perhaps it's not good for the human kind as a whole. Thank you.
Yes, thank you very much. It is a very interesting question, a very delicate one, because traditionally, regarding genetic engineering in humans, when it began at the United States in the 90s, it was claimed that one thing is genetic engineering, therapy, gene therapy on somatic cells. So to treat human diseases and conditions of a specific person. Of course, this has specific ethical problems because we are changing our genetic endowment, but nevertheless, in specific cases, when there is no other medical alternative, when the disease leads to great human suffering, even to early death, if the ethical principles of beneficence, non-maleficence, autonomy, justice, etc., are complied with, it is stated that some protocols should go on, because it is an extension of what medicine does for centuries, treating patients. Of course, there are two different situations now. One, treating patients, but only that specific patient, but as the genetic engineering can reach germinal cells, as you stated, all future generations will be, of course, at the scope of this intervention. It needs to be determined if the good at the end of this protocol is good enough so that next generations will also benefit from this procedure. Of course, there are risks because in genetics, nothing is certain, but if we feel as scientists that the overall good is much greater than the harms to future generations, it might be accepted. I'm being very prudent with the words. We have an ethical principle that is the precautionary principle that states that if we are not really certain, we should not go on. But nevertheless, it is a prudent line, a reasonable line, not a red line. So if science develops and we feel that, for instance, with your research, people will be better off, not only this specific patient, but also future generations, in principle, it might be ethical acceptable. What will be the challenge in this 21st century is genetic engineering, not for treating diseases, but to enhance human persons. This is much complex from an ethical perspective, because the problem of enhancing is that what means enhancing for me is not the same that means for you. So for instance, being very tall might be enhanced for some persons, but not to be enhanced for other persons, or being a man or a woman, or being black or white, or anything else. So when we are speaking of enhancement, the problem is more complex, because we cannot know for sure that the next generations want this procedure, and we cannot presume the consent of future generations. But again, precautionary principle states that it is not a red line. If in the future we have a reasonable certainty that the future generations want that genetic change, we might discuss it. So I would put it like this. I'm not saying it is adequate from an ethical perspective, but we should discuss it. It is not a red line. For instance, a very recent report from the Nuffield Council on Bioethics from London, in some circumstances allows for genetic engineering, enhancement engineering in humans. If there are no injustice in the world with this technology, if it leads to the better off of mankind, and of course, if proper consent and normal procedures in research are put forward. So it is a very complex issue, but again, it should be discussed openly, and we should gather the consensus, the possible consensus, because science has a life on itself. I prefer to discuss it globally, to reach global ethical principles, so every scientist knows what humanity feels, that to be very stringent, not allowing science to develop, because anywhere in the world these procedures can go on. And so I would prefer to have the maximum possible consensus, taking into account a common humanitarianism all over the world.
Thank you,
Thank
Professor.
you very much. Thank you very much, Dr. Frans Arifin and Professor Nunes. Dr. Arina, are you still on the line? Yeah, Dr. Arina, I have a question for you.
Yes.
To what extent could the Otitis externa to be the Otitis media? Because the canal is very close, and then sometimes the infection could extend it to the other side. Would you please explain this?
Thank you, Dr. Peter, for the questions. Well, the origin of infection itself actually very different. For the otitis externa, it comes from the outside. As one of my slides shows, that the predisposing factors usually because of the trauma, the manipulation of the ear canal and everything. And then the bacterial infection comes to the skin, to the canal, and usually can even further down to the eardrum and becomes the meningitis bullosa, like what I said. But for the otitis media, it usually comes from the inside part of the ear, and mostly involve the eustachian tube, which usually because of the infection in the upper respiratory tract, including the nose part and also the nasopharyngeal part. If we talk about the damaging of eardrum because of the external otitis, maybe because of this manipulation of the ear canal too further inside, because the ear canal itself is quite long actually. So I haven't really seen any case with start with this external otitis and becomes the otitis media, because otitis media itself usually comes from this the air cell in the mastoid process, not from the outside. I think that's my answer, sir.
Thank you very much, Dr. Arina, for your explanation. Any question from the floor? I have a question more to Dr. Gunadi. Dr. Gunadi, to what extent could we advise the parents of a patient for the Hirschprung disease that they should try first the anal dilatation before getting the surgery, or you go through to prepare a surgery for the Hirschprung disease?
Okay, thank you very
Would
much.
you please explain?
Yeah, thank you very much, Dr. Peter, for the interesting question. Yeah, actually, Hirschprung disease characterized by lack of ganglion cell in the intestine, starting from the bottom, the rectum, go to beyond to the upper level of intestine. And because of the mechanism pathogenesis of Hirschprung disease due to the lack of ganglion cell, the definitive therapy for Hirschprung is resect the aganglionic part and then anastomose the ganglionic part with the anus. How about the anal dilatation? There is no place for anal dilatation for Hirschprung disease because this is the disease is caused by the lack of ganglion cell in the intestine. So the definitive therapy for Hirschprung disease is to resect the aganglionic part of intestine and to anastomose the ganglionic part and the anus. I think that's the answer, Dr. Peter.
Thank you very much, Dr. Gunadi. Any other question from the floor? If there is no question anymore, we come already to the end of the session. On behalf of the International College of Surgeons Indonesia section, I would like to invite first Mr. Max Downham to address the headquarter impression of this session. Mr. Max Downham, the floor is yours.
Thank you, Dr. Manopo. I thank Dr. Arina, Professor Nunes, and Dr. Gunadi for their wonderful presentations, as well as Dr. Purohito's summary. I related as a layperson. I'm not a physician, I'm not a surgeon. I relate particularly to the key topic from Professor Nunes. He said a word that is a very major or key word, I think, in the English language, and that's trust. If I trust someone, and I'm a retired business person with a chemistry and physics background in terms of science, if I trust someone as a manager, I'm willing to take more risk. If I don't trust someone, I'm willing probably as a manager to take less risk, all other things being considered. So it seems to me that the point made by Professor Nunes is very key, and in terms of trust and how it relates to risk. And of course, as Dr. Gunadi pointed out, he represents the new technology, stem cell, and the discussion. And of course, if I'm a patient and if I trust my physician or my surgeon, I will probably be, at least personally, willing to take more risk. If I'm not certain, or if I don't trust the physician or the surgeon, or maybe I don't understand the science, then I will maybe be a little bit more hesitant to take the risk. So trust in a sense, Dr. Manopo and all others on the line, to me is absolutely key and fundamental in all of these discussions. It seems to me that that's where a large part of the debate as a layperson is. You see it in this country today, in the United States, in terms of the debate about whether how much risk a person should take in contacting COVID-19, particularly if they're younger, as compared to the risk associated with a vaccine. And so it's an interesting debate. And it seems to me in that debate that trust is a key factor. So those are my observations. In general, Dr. Manopo and all leaders of the Indonesian section, what you're doing, as I've said many times before, is absolutely terrific. You are to be commended. I only hope that other people will, and other sections in the ICS will follow your example. So thank you very much. I'm honored and privileged to, as a layperson, to be part of this, and I thank you all.
Thank you very much, Mr. Max Downham, the World Executive Officer of the International College of Surgeons. I would like to express my gratitude to our distinguished speaker, Professor Nunes, from the UNESCO Biothics Chair, Portugal, and also for Dr. Arina Ikasari and Dr. Gunadi for the presentation. To Mr. Max Downham, Professor Georgios Tsoulfas, Professor Maliawan, Professor Purohito, Dr. Frans Arifin, and all participants, and also our IT team, Mr. Bimo and Ms. Devi. Thank you very much for your contribution and participation in this venue, and we will meet again next month with the other topic and speakers. Thank you very much. Keep well and healthy. Goodbye.
Thank you.
Bye.
Thank you.
Thank you,
Bye.
everybody.
Everybody.
Prof Ito,
Bye.
Prof Maliawan.
Salam, Prof.
Yeah.
Goodbye.
Pamit, Prof.
Bye.
Stay
Thank
healthy, everybody.
Mas
you.
Gunadi,
J, Prof.
sukses Mas Gunadi.
J, J, Dok.
Assalamualaikum.
Terima kasih.
Waalaikumsalam, Dr. Indro.
Bye from
Assalamualaikum
Nigeria.
salam. Ya.
Bye from Nigeria.
Mas Maliawan.
Yeah. Good night, everybody. Dr. Ito.
Good night everybody.
Dr. Indro. Very good night. Stay healthy.
Semangat.
Yeah.